Okay, I'm sure this may not seem like the most exciting topic, but it's actually really important right now because there's a lot that's going on in this space, and I have no idea how to advance the slides, so maybe there's a clicker. Aha. So I do have some conflicts. I don't know that any of them are particularly relevant, but anyway. Like has been said, I wouldn't mind being more conflicted, but so I think pretty much everything I said has been touched on, and we can make this a talk to get back on schedule. But I just wanted to highlight that there are limitations to identifying neuroendocrine tumors when you use CT and MRI. They are important techniques. They can find a lot of the tumors, but they miss a significant fraction of the tumors. And basically, Aqueous Scan in 1994 was really a big deal. It was the first radio-labeled peptide to diagnose cancer in general. And it could find, and I'll show you just briefly, it could find tumors that were missed with CT and MR. But CT and MR have gotten better, and they provide a lot of information and they're complementary. But the new kid on the block, at least in the US, even though it's at least 20 years old, is this commercial name of NetSpot, the Gallium-68 dotatate, and it's really changing things. FDG PET, which some of you may have heard of, is sort of the big kind of more common PET scan, is useful in some of the more aggressive neuroendocrine tumors. But the thing is, the aggressive neuroendocrine tumors that were discussed earlier tend not to have as much of the somatostatin receptors on them, so they behave differently than some of the less aggressive ones. And then we're going to talk a little bit about the new peptide-based therapies, which I think are going to change things quite a lot. So you've seen this. I'm going to skip it. I think you've heard what neuroendocrine tumors are. But the thing about this that's biologically interesting are the somatostatin receptors. And this is this is looking at somatostatin receptors on the surface of cells. And we actually can target these little brown things, and they represent the way that these radio-labeled peptides actually accumulate. There are peptides that specifically bind to the structure of the somatostatin receptor type 2 and will home to those tissues and then be internalized in neuroendocrine tumors. So this is way too much information, but basically, if you can get the right molecules, you can treat symptoms with octreotide, and then octreotide was modified to make the radio-labeled peptides that bind to the somatostatin receptors. So we are going after somatostatin receptors, and if the neuroendocrine tumor doesn't have much in the way of these receptors, they're not good candidates for imaging with this agent. So, as was pointed out, this has not exactly been the fastest progress. The somatostatin analog octreotide was first used in 95, 2005, 2005, 30 plus years ago, and the first human imaging was reported in something like 1989, and again 1994 is when Aqueous Scan became available. So this has been coming along, and the first radiopeptide therapy, the so-called PRRT, was introduced in the late 90s. And we'll just go through here. But so this has been coming, and you notice that this refers to yttrium-90. There was an attempt to get this thing approved, yttrium-90, some years ago. It didn't work as well as the lutetium has, and it's just not like you can attach every different radio label and have it work the same way. But anyway, there's been a lot of action, and I won't do much other than to say, here's a chemical structure. I thought if anybody was a chemistry major in college, you'd enjoy this, but I don't know how many were. But anyway, you stick the radioactivity onto this thing, and this is Aqueous Scan. And this is one that looks about like it, and then you can have indium or you can have gallium. So this Aqueous Scan, this is what it says on the label. Basically, you've heard that it images these tumors. And we can image with either PET or SPECT scans, okay? And just ever so briefly, the SPECT CT kind of looks like this. Has anybody in the room had an Aqueous Scan? Quite a few. So you probably had a machine that looked like this. These are getting better and better. They let one look inside the body, and Aqueous Scan is a very good tool. And this is sort of how the early machines look. Now they're better CT scanners as part of this. The CT helps one localize where the radioactivity accumulates. So just as review, just so you can kind of know the difference between the two scans, the Aqueous Scan is done, the mass of the stuff that's given is much less than that's given therapeutically. So it's what we call a tracer dose. And roughly, a patient is injected, well, first of all, many people will say you should be off the Aqueous, the somatostatin or something for a week. The evidence for that's very minimal, by the way. If you're on a long-acting somatostatin type agent, sort of at just before the next dose is when this is often given. Patients are injected, often imaged 4 hours later, often imaged 24 hours later, because there's some excretion of this stuff into the bowel. They're sometimes imaged 48 hours later. So it's a 1-day to 2-day procedure. So I'll come back to gallium in a minute, but gallium is done within 2 hours. So that's one of the nice things about it. It's a 1-day, it's just like a morning kind of thing. So here's what an Aqueous Scan could look at. That's a 3-dimensional image. A CT is on your left and the Aqueous Scan on the right. Those two things that look like C's are actually the kidneys, and then there's our focus there. And this particular patient also had a tumor in the neck. You see a spot up there. We see activity in the bowel, we see activity in the kidneys, we see some coming out of the urine. But this is what an Aqueous Scan looks like. And this was a major advance. Now, on the product label, it says that based on what was supposed to be truth, this stuff missed about 20% of the tumors. But I think the data shown earlier by Dr. Anthony from the NIH showed that we probably missed 70 or 80% of tumors with this technique. So it's always hard to know when you go to something more sensitive what you were missing until you get there, and I'll show you some in a minute. This works best in carcinoid and gastronoma, and somewhat less well in some of the more atypical types of tumors. Now, PET-CT, how many in the group have had a PET-CT performed? A smaller number. So a PET-CT can be done with a variety of radiotracers. Relevant to this is probably the Gallium-68. But in brief, it's a PET scanner and a CT scanner sort of stuck together. I thought I had a couple of slides on this, but they're physically joined, and you can get images of both anatomy and function. And so you get form and function fused. Now, this was approved in 2016, Gallium-68 dotatate, and I think it's a real advance, and it's, you can read the label here, somatostatin receptor positive neuroendocrine tumors in adult and pediatric patients. So the nice thing about this is it's injected. The preparation is similar right now. Wait 40 to 80 minutes. We typically wait about 60 minutes. Scan for 30 minutes to 60 minutes, and then the whole imaging thing is done. So it's a less of an investment of time. You have less time involved. But the good thing about it is it's far more sensitive than an Aqueous Scan. This is what the Aqueous Scan kit looks like. The material is non-radioactive, and then it's mixed up and then injected. That's pretty routine, but the use of this is declining fairly rapidly. Oh yeah, here we go. Here's the PET-CT scanner, sort of the CT and the PET. Patient lies down, goes through, gets both. This is what one looks like. This is an early generation. The good news is probably half an hour or so in the scanner. The bore is a little tight sometimes, but a fairly well-tolerated procedure. I'll show you an example of we've been doing this quite a lot at Washington University. We have a large hospital, Barnes-Jewish Hospital, where we conduct some of our radiology. It's a patient with a suspected, well, actually, a different kind of tumor, melanoma in the history, and had an FDG PET scan, in part because there was an abnormality on CT, and the FDG PET, this is glucose metabolism. You don't see a bright spot, and this is in 2014. This was basically kind of negative. There's uptake in the brain, but this is negative. So there's anatomic abnormality, but a negative scan. So maybe that's good, maybe it's nothing. But biopsy showed metastatic carcinoid tumor. And going back, here's the gallium-68 dotatate. There's intense activity throughout that and intense activity in the liver. So this was completely missed on the FDG PET. We see this here, that bright spot. It just shows you how the different tracers can have different results. And this is, anyway, here, this is a review from last year, superior detection of tumors compared to Aqueous Scan, MIBG, MRI. And as was pointed out in the article in the JCO from the NIH, there's about a threefold better lesion detection rate with gallium-68 dotatate. So here's that patient, FDG PET, negative, and the gallium dotatate very positive. Here are some other examples. The C here is an Aqueous Scan, and D is a patient with a gallium-68 dotatate. And it's hard for me to point at both screens, but you can see many more spots on the gallium scan. So this is typical. Here's another one, A and B. A is the Aqueous Scan, B, the gallium-68 scan, and you just see many more lesions. The P is the normal pituitary that shows up commonly, but to make a long story longer, the gallium-68 dotatate is simply a better agent. So here's some of the data in the FDA label. This is FDA approved. I won't belabor it other than to say in several studies it has performed superiorly to other methods. And it's quicker, better sensitivity, and a negative predictive value. And here's what's happened to our volume. I asked our chief tech to look at our volumes of cases per month with Aqueous Scan versus dotatate. And the blue line is the Aqueous Scan volume going to 0 in August, and the sort of reddish orange line, at least on this screen, is the gallium going to 18 or so in July. So just a complete change in our practice pattern with the introduction of this agent. We still have both available, but essentially once the knowledge was out and the technique was available, our total practice shifted to this agent, and I think that's happening. One of the disadvantages with this agent, sort of as a new agent, is you need a gallium generator, and the gallium generators are in short supply, and not every place can have it. So the geographic penetration of this, you can see that if you're in the Intermountain West, there's not a lot of sites that are offering this technique. In this part of the country, there is pretty good availability. And indeed, I was wondering what's available in Indianapolis. And I just, on the web, I found out how you order scans here, that it's available at Indiana University. So you don't have to come to St. Louis, although we'd be happy to see you if you're close to St. Louis. But it looks like you can get these scans here. And we know that, and here's the form, and here's some of the indications. They list 4 possible indications. I don't want to belabor this, but in the recent literature, there's a appropriate use criteria that were just published in the Journal of Nuclear Medicine, showing that there are at least 9 specific reasons that one might get a dotatate scan. And if you want to discuss those, and if your doctor hasn't ordered it, you might want to just pull out the 9 reasons to get the scan. I have it in my pocket here. I won't read them to you, but there are quite a few, including patients who have symptoms who haven't yet, suggestive of NET, who haven't been diagnosed yet. And certainly if any surgery or aggressive procedure is planned, you really want to have a good staging procedure before the surgeon does all that to your liver, and then you find out, well, that there was even more. I mean, that debulking certainly has a role, but knowing a roadmap before surgery can be very helpful. And if the disease is best seen with this technique, it may also be the best technique to follow therapy. So anyway, this is just a form. So these techniques are becoming available. You're going to have to travel to a referral center. So here's just a little study we did when I was in Baltimore, just to show you that I think that this business about having to be off the octreotide is probably somewhat untrue. These are some patients that we actually did retest with the gallium-68, and we see a baseline study there, and we see a study on the right that was done when the patient, this was a prospective trial, where we gave octreotide IV an hour before doing the scan. And the liver background went down, the spleen went down, and the tumors went up. So it's kind of a paradoxical effect, but actually you may be better off staying on octreotide. That's not what the label says, but this needs further study, but I think it's a very interesting set of observations, and it's statistically relevant. Well, the clock is ticking, and I haven't got us back on schedule yet, but I think it's important to talk about the therapeutic applications of this technique. So if you can deliver the activity selectively to these tumors and diagnose them, then what about treating them? Well, the answer is it does work, and here's a whole book that's just been written on therapeutic nuclear medicine. It's 1,000+ pages. This area is growing rapidly. There's been a lot of work in Basel where this was developed. I think it's too long to go through this stuff in detail, but basically, if you get down to the chart of ways and things aren't working with surgery, and the tumors are low enough grade that they still have somatostatin receptors, then PRRT will fall into the treatment regimen. And in general, the more the accumulation, the brightness of the tumor, the more probable it is the tumor will respond. And that's called, you can talk about a tumor uptake score or a Krinning score. And here's a patient, again, from the Basel experience. This slide was given to me by Damian Wahl from Basel. But here's a patient before treatment, and let's see what's happening. And here's after 2 cycles of Dotatok, yttrium-90. So this is not the agent that was approved recently in Europe, the Lutathera, but it's a precursor agent. But these can certainly cause tumors to remit and get smaller. And here the scan hasn't completely normalized, but it's gotten better. So this is encouraging before and after PRRT. And generally, the more the dose to the tumor, the more likely it is that the tumors will respond. So this isn't unexpected either. And what is typically done, and what the regimen developed in Europe, is typically 4 doses of the radiopeptide labeled with lutetium-177, which is a radiolabeled compound. And this is a patient we treated in St. Louis. It's a little hard to tell, but the lutetium is not a PET emitter, but we can also detect it. So this is a patient with extensive liver metastases. This case was imaged at our institution after therapy. And here we see some bone metastases that are accumulating the lutetium in a patient in one of our studies in collaboration with radiation oncology. And here's some bone metastases. So very nice targeting with the therapeutic agent. So the radiation is going to the tumor, treating the tumors, and not hitting the normal tissues to a great extent. This article was already referred to by Dr. Anthony, and I think I'll just go through it ever so quickly. This is a prospective, multi-center, phase 3 trial of the lutetium-177 dotatate, and you can read the rest. I will not read you all the authors, but this indicates that it was a multi-center study. And I know this is hard to see, but these are basically randomized to a control group that received long-acting somatostatin receptor therapy versus lutetium dotatate, a little over 100 patients per group. And we see that complete responses really are not very common. These tumors do not go away by imaging. Partial responses are relatively uncommon. 17% of those patients treated with lutetium dotatate had a partial response versus a control group. But this was significant. And adverse events were relatively evenly distributed between the 2 groups, but treatment-related adverse events were more common in the group that got the lutetium. And it's hard to see this, but the most common adverse events would have been some nausea, some reduction in white count, and those were 2 of the more common things. And then with time, one might expect decreased renal function in some individuals. This doesn't show up well, but I think you've seen this. There's some very dramatic differences in the survival curves of the patients treated, but the blue group was the lutetium. This is a progression-free survival versus the other control group. So this is a major and significant difference in outcomes. And the summary of the New England Journal said, and this was in 2016, I think, patients with midgut tumors that had progressed during octreotide analog therapy, the addition of the lutetium, resulted in an 18% response rate and a significantly higher rate of PFS at 20 months. This certainly suggested a survival benefit, and clinically significant reductions in bone marrow function were only seen in 10% of patients. And that's really not a lot. I mean, it's an issue, but it's often manageable and less than often seen in chemotherapy. Now, searching the internet for true news, this is public, but September 29th, 2017, the Lutathera, this therapy was approved in Europe. So I think that's quite exciting. And this was based on the NETRF study and safety data from over 1,200 patients with a wide range of treatments. And they also had you don't have to, obviously don't have to read this, but the updated data that they used to get the European approval was a 46% reduction in the risk of death with this agent. So a significant reduction in the probability of the hazard ratio versus octreotide therapy, long-acting 60 milligrams. And I just wanted to point out, I think that this was, yes, just to point out, if you read the bottom line here, the approval allows for the marketing of this agent in all 28 European member states, as well as Iceland, Norway, and Liechtenstein. So there you go. So, although not quite yet here in the US, just so you know, not everybody necessarily can get the full dose. Some people had some toxicity. There's some adjustments that may be required. Here's the way the therapy goes, at least per the package insert. Patients receive an antiemetic, and then they receive an infusion of amino acids over about a 4-hour period. This is designed to reduce the uptake of the radiopeptide into the kidneys. If that's not done, the renal radiation dose may be excessive. I think most people who've done this feel that the amino acid infusion may be the hardest part of this because some patients get nauseated from this. The radiopeptide is given over about 60 minutes, started about 60 minutes after the infusion of amino acids and is infused over about half an hour. So this is a relatively slick, it's probably pretty close to a full day, but I think the amino acid infusion is probably the most difficult part of this. So this is the therapeutic indication per label in Europe, indicated for treatment of unresectable or metastatic, progressive, well-differentiated G1, G2 somatostatin receptor positive GAP-NETs in adults. And I think, and it's recommended that there be 4 infusions. So I think that this is very exciting. They say that the somatostatin analogs should be avoided for 30 days prior to this therapy. I'm not as sure about that, something that probably needs further study, but they say short-acting can be used up to 24 hours beforehand. So this has been available on a compassionate use basis in the US. This compassionate use is, I think, just ending with hope that the FDA will approve this. It is not yet FDA approved. I need to make that clear as a disclaimer. But I think it's close, and I think that they're supposed to provide some answer by the end of January. And a big investment in this field is the fact that Novartis recently announced at the end of October that they plan to acquire the manufacturer, AAA, to strengthen their oncology portfolio. And their engagement, I think, will be a big help to this becoming more widely disseminated. And I noticed that their price for this, that said it was $3.9 billion in cash. So I think that this is certainly indicative that they think this has great value and will have great impact. My concern at paying $3.9 billion is I don't know what this is going to cost, but they're probably going to have to figure out how to get back more than that. So, but FDA-approved cancer drugs typically that are effective are typically paid for by insurance and so on. So to summarize, diagnosis of neuroendocrine tumors, certainly CT and MR are still important. I think that a peptide-based imaging agent is important, and if you can get access to the gallium, it's clearly the superior test. And I think we're going to see a big change in the availability of therapies with radiopharmaceutical therapy, with PRRT and presumably Lutathera. I think that toxicity is mainly nausea, and I think we'll do well with it. I think we've seen this approval in Europe. We've seen the approval of the therapy in Australia, and The only caution I'd say is if this gets approved and you have private insurance and you want to get it, your insurance may not understand it yet. And there have been challenges, even for the diagnostics. As an example, Aetna, I don't know if they're headquartered here or not, but they're known for thinking most things are experimental for a long time. Everything's experimental. But they've considered gallium-68 dotatate experimental, even though it's FDA approved. So you may have to file appeals, and you may have to get knowledge of your policy, and I would refer you to the Northern California PET website, which is very helpful in this regard. And that's pretty much what I want to say. I've got to thank some people who contributed some slides, and thank you for your attention. Okay.